Okay, so it looks like people are joining us. So what I'm going to do, first of all, is introduce myself and talk a little bit about this webinar. My name is Niall Boyce, and I am Head of Field Building in Mental Health at the Wellcome Trust. Now, this webinar today is hosted by the International Alliance of Mental Health Research Funders, IAMHRF. Now, IAMHRF's job really is to help coordination and communication between various funders in this very exciting field of mental health, and to really help us as well to tangle with some of the more difficult issues in research funding and in mental health science. And today we're going to be talking about one of the most exciting, but also one of the most controversial areas in mental health science over the past 10 years, and that is psychedelics as therapeutic tools in mental health. Now, this is an area which launched with a great deal of excitement a few years ago. There have been ups and there have been downs since. At the moment, I think that there's a bit of a sense of questioning around this whole field. We know that earlier this year, the FDA rejected the application for MDMA to be used as a therapy for post-traumatic stress disorder. And indeed, just this week, the Atlantic magazine, very influential magazine in the States, published an article called The Weak Science Behind Psychedelics. So it's really time, I think, to try to make sense of psychedelics, to say what's hope, what's hype, where's the evidence, and what's the future. And we're really lucky today to have three fantastic speakers to help us to navigate these difficult waters. The first person we're going to hear from is Professor Allan Young, who co-leads the Psychoactive Trials Group at King's College in London. And this group runs controlled clinical trials with psychedelics and related compounds. He also holds the chair of mood disorders. He's the director of the Center for Affective Disorders at the Department of Psychological Medicine in the Institute of Psychiatry, Psychology, and Neuroscience at King's. And he's also the vice dean for academic psychiatry. But he's also the clinical academic lead in psychological medicine and integrated care clinical academic group at South London and Maudsley, where he's also a consultant psychiatrist and head of the National Affective Disorders Tertiary Clinic. So we have a real heavyweight to kick us off. We also have Professor Cuijpers, who is very well known as Professor Emeritus of Clinical Psychology at the Department of Clinical Neuro and Development Psychology, and that's at Vrije University in the Netherlands, in Amsterdam. He's also director of the WHO Collaborating Center for Research and Dissemination of Psychological Interventions. That's also based in Amsterdam. And he specializes in conducting randomized controlled trials and meta-analyses on prevention and psychological treatments of common mental disorders across the lifespan. And you might have read in JAMA Psychiatry a short article which Pim published the other week on specifically looking at the psychological component of psychedelic therapies. It's well worth a read. And then the final speaker we have today is Dr. Florence Butlen. And Florence is a clinical psychiatrist with a scientific and regulatory background. So she started her career at a teaching hospital in Paris and then worked at the European Medicines Agency, the EMA, and was there the topic lead in psychiatry. Now, Florence has recently resumed her clinical activities at a teaching hospital, and her research interest is really in the investigation of psychedelics for psychiatric disorders. So the format that we're going to have today is that we're going to hear brief presentations from the three speakers, following which I'll have a brief follow-up discussion question. What we'll do at about 3:15 UK time, 4:15 probably Central European time or wherever you are, is that we'll then throw it open to the audience Q&A. And what I'd encourage you to do for that is to go to the top of your screen where you'll see the bar with the various Teams functions on it. And if you tap on Q&A, you can put your question in there. Those questions will get sent to me, and I promise you we will get through as many as we can. I'm sure there'll be a lot of questions and a lot of discussions. We're going to do our best. But the first thing to do is for me to stop talking now and to introduce our first speaker, who is Professor Allan Young, who's going to be talking about really the sources of variability and some of the issues involving running trials in psychedelic medicine for mental health disorders. So I'll just hand over to Alan. Thank you, Alan.
Thank you very much, Niall. And if we can go to the first slide, and whilst we do, I'll just say thank you very much for inviting me to speak today, and it's a particular pleasure to speak with the other two distinguished speakers. So I'm briefly going to go through some of the background issues. I very much liked what Niall highlighted with the Atlantic article about weak science. And if you wanted to define what strong science was, it's really asking tough questions, and the tougher the better science. So I'm going to look at some of the issues about psychedelics right now. Next slide, please. These are my disclosures. We've gone through most of this. We are active in doing psychedelic trials, and we do have grant funding from commercial entities in the field, including Compass and others. Next slide. So as Niall said, there has been a resurrection in interest and work in trying to determine whether psychedelics have therapeutic properties. This has been mostly in depression and latterly in treatment-resistant depression. Psychedelics were, of course, banned in the early 1970s in the US and internationally. But because of the work at UCLA, New York, Hopkins, and then Imperial College and so on, we've seen really much more work in this area. And of course, there's great therapeutic optimism. But I think the key point is that any new treatment, even if it's psychedelics, needs to be scrutinized for benefits and harms. Next slide. So this is a New England Journal paper that was published about 2 years ago, led by Guy Goodwin, with a cast of thousands, including myself and others on it. The essential results are shown in the next slide. Next slide. So this is non-placebo controlled, single dose of 3 ascending dose of what is called Comp 360 or psilocybin, 1 milligram, 10 milligrams, and then 360. And the MADRS scores are shown on the y-axis with time on the x-axis. And you can see these patients who had treatment-resistant depression, about 30% showed a highly significant benefit, which was greater with the higher dose of psilocybin. And 2/3 of those would show an enduring effect for 12 weeks after one single dose. So very exciting, albeit preliminary result. Next slide. So the obvious questions are, well, first of all, does psilocybin work? And the short answer to that, we might hear more from Florence, as it needs to be replicated in larger trials. And indeed, these are underway. And these larger trials should also not only look at efficacy, but look at adverse effects. But how does it work? Well, we know the pharmacology. We know that psychedelics are 5-HT2A brain receptor agonists. But there's some dispute about whether this is fundamentally a drug that enhances psychotherapy, a drug experience that changes your mind or changes your brain, in that they might be different, or whether the psychedelic phenomenon are epiphenomena, not actually necessary. You could perhaps have a medication that did this, and even if the person had no psychedelic symptoms, they would show benefit. I think that's unlikely given what we've seen about the ascending dose effect from the New England Journal paper, but let's tease these questions apart over the next few slides. Next slide. So this is, first of all, from our therapists in the group that James Rucker and I run. They compiled a little table of the different psychological treatment models. We'll certainly hear more about this from Pim, and I look forward to hearing what he says. But just to say that there's different models from psychological support, cognitive behavior therapy, brief support, expressive group therapy, acceptance commitment therapy, and so on and so forth. Niall mentioned the MDMA work, and although remember, MDMA is not really a psychedelic per se, there are different psychological models used there. So one potential source of experimental variability is using different psychological models. I'm not actually aware of consensus about which model would be best, but again, I'd be interested to hear others' points of view. Next slide. This is the altered states of consciousness that were measured in the New England Journal paper. you can see measuring things like oceanic boundlessness, anxious ego dissolution, auditory alterations, visual restructuralization, and reduction of vigilance. Next slide. Changes during the session in these altered states of consciousness were correlated with the drop in depression scores in the treatment-resistant depression. And as you can see, as you move from the 1 milligram to the 10 to the 25, the actual correlations got somewhat stronger. So this is some evidence suggesting that the correlation between the psychedelic-induced alteration in consciousness is associated, perhaps causally, with the improvement in depressive symptoms. This, of course, is unpublished data, but it will be coming out at some point in the near future. Next slide. In the same type of analysis, we didn't find a relationship between aspects of the psychological support. I've got no doubt that psychological support or psychological input is very important for safety and for integration, but during the actual therapy session, or related to the characteristics of the therapist-client relationship, there didn't seem to be a particular effect, although there was a suggestion that 25 milligrams amplified positive experience, suggesting a true psychopharmacological interaction. Next slide. So to conclude this first part with one further slide about gaps, some gaps that I've highlighted. I think there's preliminary evidence that a high-dose psilocybin, 25 milligrams, one-off session is a potential treatment for depression, treatment-resistant depression. But of course, this needs to be verified in larger studies which are underway at the moment. The pharmacological action of psychedelics is primarily serotonergic through the 5-HT2A receptor, but there will be different pharmacokinetics. Psilocybin, for example, is a prodrug of psilocin, and it actually, the sessions can last sometimes 8 to 10 hours. There are shorter acting psychedelics, which may be more practicable. Also, although they all have the common action of being 5-HT2A agonists, they have other effects, and we don't know whether effects on other 5-HT receptors or so on, or potentially other neurotransmitter systems may enhance or detract from the therapeutic benefit. The data from the New England Journal of Medicine trial support the development of psilocybin for treatment-resistant depression, and really this means further trials, phase 3 trials, in an attempt to get a license. And measuring the psychedelic experience may be useful because of its potential as a pharmacodynamic marker of drug effects. And in the last couple of minutes, I want to go through some of the gaps in the next slide. So gaps and outstanding questions. What are the optimum treatment protocols? Which compound would be best? Which dose? Which frequency to maximize the treatment response? Some people may need more frequent dosing. I mean, it seems to be clear that you get benefit from a single dose, but would some people require multiple doses? Next build up, please. What is the duration of the therapeutic effects post-treatment? It's measured out to 12 weeks. I suspect most people will not see a therapeutic effect much longer than that. We hear anecdotal accounts of people being cured forever, but of course they've not been followed up forever. Next slide. How do other mechanisms that we know are germane to antidepressant effects, monoamine signaling, network activity, neuroendocrine, anti-inflammatory effects, contribute or detract to the clinical benefit from these compounds? Next build up, please. Are the acute dissociative hallucinogenic effects necessary? I suspect they are, and I've shown some evidence to support this, but of course, this is not absolutely confirmed yet, and further work should be done. And there's interesting experiments that might be done. Next build up. Are there additive or synergistic effects with psychotherapy? I'm pretty sure there are. Lifestyle interventions and other treatments, including exercise, neuromodulation, and so on. And last build up. And lastly, there's huge therapeutic optimism for depression, but psychedelics are being applied to other neuropsychiatric disorders, things as diverse as anxiety disorders, eating disorders, perhaps early neurodegenerative disorders, and functional neurological disorders. All of these will require to be tested and examined for benefits and harms in the same way. I'll stop there and thank you very much for your attention and hand back to Niall.
Thank you, Alan. So I'd like to return us to this question of the science, the strength or the weakness of the science, and looking specifically at the issue of trials, clinical trials and psychedelics. Now, I know that sometimes the methodology of certain trials has come under a great deal of criticism. And on the one hand, you could say, well, there are some aspects of psychedelics which make clinical trials very difficult. For instance, you tend to know if you've taken a psychedelic or not. So placebo is a difficult thing to really engage with. But then there are other areas where you can say, well, there are very straightforward ways that we can strengthen the quality of these trials and the evidence that comes through. So what I'd like to hear briefly from you is what are the superable obstacles, what's the insuperable obstacles, and what can we do about these things which we can't change when it comes to running psychedelic trials?
Well, thanks very much, Niall. So one problem is the lack of the placebo control. And as you've said, you would need an active placebo, but then you'd need an active placebo that could cause psychedelic effects. Therefore, it wouldn't be a placebo. Now, the dose-response relationship is some answer to that to show causality under Bradford Hill's causality criteria. There's a really neat paper being published with ketamine, where people who had depression and who were undergoing anesthesia were given ketamine, not as an anesthesia, but whilst under anesthetic. So there's no conscious experience. You could do something similar as a proof of concept experimental study with psychedelics. You probably need to use a very short acting psychedelic, but nevertheless, it could be tackled in that way. But I think the placebo lack is a major limitation in the field. I think also when we look at the people that come into these studies, they have a huge preference for psychedelics, and patient preference can really be a powerful effect on the benefit of the either positive or negative on the intervention. So I think the lack of placebo control, the lack of an active control in terms of looking at preference, placebo effects, and so on is a major limitation. I don't think it's totally insuperable, and I think there are ways that this could be asked very, tough questions could be asked of this. But I think at the moment we're in danger of saying, oh, well, we can't do a placebo, therefore, we'll just have to take it as read, and that would be a mistake.
Thank you. So I'm sure we will discuss this further later. If you've just joined us and you have questions, do pop them in the Q&A box of the chat, and we'll get to as many as we can later. But for now, I'd like to turn to Pim Cuijpers, who's going to talk about being realistic about clinical impact and a little bit about the psychotherapeutic element of work in psychedelic medicine. Thank you, Pim.
Thank you, Niall, and thank you also for inviting me for this webinar. And Alan, thank you for a wonderful first lecture. I want to build a bit on that. Can I have the next slide, please? I only have 10 minutes, so I can make only a few points, and it's not possible to give an overview of everything in the whole field. So I've picked a few key points. One is that we should be clear that although these drugs have the potential to improve treatment outcomes, that potential is small, and it is for a small group. That's the first thing I want to show. Then I want to talk about the long-term effects, and Alan already talked a bit about that, because these drugs, they are drugs, and of course they have a short-term effect, otherwise they wouldn't be drugs. But the issue is whether they can work at a longer term. And the third thing I want to talk about is a few of the methodological problems that we focus in this field. Can I have the next slide, please? So first, the limited potential for a small group. Can I have the next slide? So these are the effect sizes of psychotherapy for depression over time. And these are standardized mean differences. The effects of psychotherapy and antidepressants are comparable. And this is what you see of the effects of treatments over time. And what you see is that they have not improved. The effects are good and they are treatments are effective, but they have not become better over time. Despite all the promises of all these people with new therapies, new treatments, none of them has shown that a new treatment is better than the ones we already had. I'm not saying that's true for these drugs, but it is still something we have to think about, because I've heard too often the story that new things are better than the things we already had. Can I have the next slide? This is what you see on the horizontal axis is the number of treatments that people can get. And at the vertical axis, you see the cumulative response rates. So if people get a therapy, the response rate is 41% in treatment in the red line. If they get usual care, the response rate is 16-17%. If these, let's say 40%, that's a very conservative estimate of these 40%. But if people don't respond to the first treatment, you can get them a second one. And if that's as effective as the first one, you end up with 67% of people who responded. If people have had 3 treatments, 80% of them have responded. And let's assume that you have these people who have not responded to 3 treatments, and you give them a new treatment. If all these treatments are, if you assume that these treatments have the same effect, regardless of the previous number, which is not completely true, but assume that, then about 40% of those people also get better. And what you assume with psychedelics is that you improve that response rate of 40%, which is the normal response rate for a 4th treatment, that you can improve that. And suppose that you can improve that to 60%. What you see in this figure is that you will have a very small group of people and a little bump in the red line and nothing more. So you will improve the lives of a few people who have not responded to a few treatments before. And that's very important. I mean, it's a terrible disorder, if you don't respond to treatments, that's even worse. So I'm not questioning the clinical relevance of this, but it is a small benefit for a small group of people. That's something we have to keep in mind. Can I have the next slide, please? Okay. What is important is that psychedelics can have a different mechanism, and that's important. I will come back to that. Can I have the next slide, please? Can I have the next slide? So this is my second point. So when I was a teenager, I used LSD, and I have to be very honest on that. That was really an intensive experience. And it shows you things in life that you really cannot see in another way. So it's a very intense, very intense experience that can change your life. But when I think back of that, if I would have had a mental health problem at that time, would that have changed me? Would that have changed my mental health problems? I'm not sure of that. It could be. I mean, I didn't have a mental health problem, and it's a very intensive experience. But it's not so much the experience itself that counts. Of course, that's important for an acute reduction of the symptoms. But then, yeah, you give people a drug which is meant to make you feel better, and that's what it does. But the question is, does it change you at the longer term? And I'm not sure. Maybe it does, but maybe it doesn't. And we really need very rigorous research to show that it has not only has an effect on the short term, but also on the longer term. And we need large, well-designed trials. And I know the trial from in the New England Journal of Medicine, which is an excellent trial, which is exactly what we need. And that's, I hope we get more of these trials. And then also for the longer term, because at the short term, I'm not so impressed by effects at the short term, because yeah, that's what drugs do. That's what drugs are meant to do. They make you feel good. And of course, you don't feel depressed anymore. Can I have the next slide, please? And that brings me to my last point. Can I have the next slide? Well, one problem is if you look at the psychotherapy part of interventions like this, when you give people psychedelics or MDMA, and you support that with psychotherapy, you can do a normal, you can do CBT, by the way, but if I think of the experience of LSD, which I had myself, I don't think it would help change me how I think, how I thought, or you should adapt your therapy to the experience you have with psychedelics. And that makes it difficult to examine, because then you have a new therapy and you have a new drug, so to say. And then you can only examine the combined treatment, because you cannot give a treatment in combination with MDMA and then say, okay, we're going to leave out the MDMA and give you still the 4-hour session of therapy, which we were planning to do. That doesn't make sense. So that's methodologically, that's a pretty difficult thing. Can I have the next slide, please? And another key issue is that we know if therapies work, and that's also true for psychedelic interventions, but we don't know how they work. And that makes it very difficult, because that will also be true for psychedelics, psychedelic supported therapies. Randomized trials can show if a therapy works, but they don't show how it works. And in order to examine that, you need much more extensive research. And of course, there are many methodological problems. If you would, Alan already mentioned a few, but if you want to know more about that, you should really read the paper from Van Elk and Eiko Fried last year. A few important problems are, of course, conflicts of interest, which can be very important in this field. Many trials are spinned so that the outcomes are negative, but it shows as if it is positive. Control groups are complicated. That's what we already discussed. Long-term effects, expectations, and researcher allegiance, which is a very big thing in this field. And yeah, can I have the next slide? I think I will stick to this because I'm over time. Thank you very much.
I'm sorry, I had trouble unmuting there. Thank you, Pim. I'm just going to follow up with a question on this issue of the psychedelic versus the psychological here, because these therapies, as you pointed out, they're largely given alongside psychological therapies. So to what extent are what we're calling psychedelic therapies actually drug-enhanced, medication-enhanced psychological therapies?
Well, that's a very good question, and the only right answer is that we don't know. You could examine that relatively easy. I mean, if you take psychedelics, that's a very intensive experience in itself. And so you could say, okay, we're going to do a trial in which we give psychedelics with only supportive therapy, with only a therapist being there, supporting, making sure that nothing bad happens. Or you can compare that in a randomized trial with the same psychedelics, but then with a good therapy, which is designed to be given together with the psychedelic. And that would show if the therapy would have an additional benefit above the psychedelics. And I mean, this is the kind of research that we need. But you need very large sample sizes to do this. You need a lot of patients. You need a lot of logistics to find enough people for this. But that's really the way forward, to do that kind of trial.
Thank you, Pim. So again, this is not an insuperable obstacle, but it's a matter of trial design. It's a matter of the scale of the trial. Maybe, of course, that makes it a matter of the funding. This is, again, a discussion to which we can return later. And if you have questions, please do pop them in the Q&A. But I'd like to stick with this issue for a moment of the psychedelic and the psychological. This is one of the reasons why I think the FDA were not entirely sure about MDMA. They regulate medications, but the MDMA for PTSD was really part of a package. It was MDMA with a psychological therapies. So there's an issue here as to how regulators manage this issue and other issues involved in psychedelics. And for that, we turn to our third speaker, who is Florence Butlen. And Florence is going to discuss regulatory issues and other issues with psychedelic therapies. Thank you, Florence. Please go ahead.
Thank you very much, and thank you for this invitation.
You're quite quiet. I'm not sure if you can maybe. Okay, shall we try that again?
Can you hear me well?
I can't hear you very well, I'm afraid. I'm not sure if other people have a problem. I don't know if it's the microphone in your computer or.
I don't know. Is it better now? It was,
okay. You're still quiet. Yeah. So I'm just getting a message as well that other people are having a bit of trouble hearing you. So I just wonder if it's the microphone in your computer, and if so, if you can lean a little closer to it, that might help. Okay, let's try that again when you're ready.
Okay, no, thank you. Thank you very much for the invitation. Is it better now?
Yeah, I can hear you okay now.
Okay.
I'm hearing a bit of feedback from my side of the microphone, but that's fine. I'll mute.
Okay. No, I'm very pleased to be here and part of this panel. So next slide, please. So I'm a former employee of EMA, so it's a disclaimer. So, but this is my own views. So please don't quote more than that. Next slide, please. As an outline, you've heard from the previous speakers, of course, there is a huge unmet medical need in psychiatry, and there's been not so much innovation in the field lately. So psychedelics kind of trigger a huge hope and kind of hype as well, because of patients obviously and doctors waiting for more treatments, more effective treatments. But obviously, there are a number of challenges, and beyond potential opportunities, there are also regulatory challenges. And I'm going to just go through a few of those in this presentation. So next slide. So yes, at WeTalk, we have difficulties basically to translate, the advances that have been made in the pathophysiology of the disorders into new treatments, which act faster, are better in terms of efficacy, and also more tolerated in terms of safety. So this is all what it is about going towards more personalized drugs, and maybe that's something also to consider when we are talking about psychedelics, whether or not all patients would respond the same with those different treatments. So next slide. Thank you. So of course we've seen an increase in the number of trials across the globe those past years. And as we know, it's not the first time those drugs have been investigated, but maybe not under the same requirement and set of standards as we have now with EU pharmaceutical research. But obviously, after the 70s, there's been a stop, and it has stopped abruptly because also of the classification of those drugs being now since then under the 1971 Convention on Psychotropic Substances as Schedule 1. So next slide. So as in Europe and elsewhere, obviously over the last maybe a bit less than 10 years, we have had a number of events that are quite interesting to follow, and that has been also in the press, and it's a few of those important dates are on this slide. Lately, a news that has been also out there, and which was a decision of FDA not to approve MDMA as a psychiatric treatment for PTSD. But before that, there's been a number of guidance given either by the US jurisdiction or EU jurisdiction, and Australia has also made a move towards a very specific way of authorizing the drug by some authorized prescribers. So it's probably very early days. So we see hopes, we see also challenges, and some non maybe successful stories yet, but this is very early days. So next slide. At European level, there's been also a great interest around those new treatments, and trying really to understand what could be their potential and how to assess, how to determine their efficacy and safety profile in a rigorous and scientific manner. So without any prejudice, but looking at the data as it is done for any other treatment. So just few pieces of literature on this slide that you are obviously very welcome to read, and that I think reflects quite well what is the current thinking, at least at European level, on this topic. Next slide. Thank you. So this is a pathway for drugs. So what is important as a message, and has been repeated in the literature, and also more recently in a workshop that has been held at European level at the EMA. You may have heard or attended that one back in the spring. It's that those drugs, although being a bit different and maybe pushing towards different paradigm, it's still drugs that would need the same level of evidence and robustness as for any other drugs. So at the very end, what needs to be shown is the benefit risk is positive, and the benefits outweigh the risks. And of course, if there are any risks, which we may expect, they are manageable. And this is not something completely new, of course, because we have approved and we have drugs in Europe which are not necessarily, so easy to manage from the safety side, but still it's feasible and it's doable, and they can be administered safely thanks to a number of tools, regulatory tools that are in place. I put few here, but I'm thinking also the previous example of a recent approved drug is ketamine. It's not psychedelic, not a classical one for sure, but there were some possibilities to implement some control access programs, some additional risk mitigation measures, And all of that allow to a safe environment for prescribers and patients. So, and we can also think of cancer drugs, which can be very toxic, but still, because of their efficacy profile, can be administered through, again, a number of safety implementation measures. And it goes as well with, you know, the labeling, what is put out there in the product information and the educational material for patients, for prescribers. Here, we have a different, obviously, element, which is a psychotherapy we've heard before. And it's important to see and to understand better how psychotherapy and medication work, how this combination work, and how this will be or not reflected in the label, because as you know, and as it has been stated before, regulatory agencies do not regulate psychotherapy, so they regulate drugs. So next slide, please. There are a number of gaps, so I'm going to go quickly through that one because it's been touched upon by the previous speaker, but it has an impact for regulatory purposes and for scientific purposes, obviously, because we need to understand more about the way those compounds work, because it turns out to be a quite heterogeneous family at the end, and maybe the drugs may differ in terms of efficacy and safety profile depending on the patient, depending on the patient population. So it's still something that needs to be further studied. And the duration of effect, it's also something very important. So maybe some drugs will last for longer, and maybe also some medicine or can have a better effect in some patients because of the profile, the specific profile of the patient, but also maybe the specific profile of the drug. So we are not, you know, obviously yet at the stage of having like biomarkers or predicting factors, but it will be important to understand better this how the drug can work and with which patient. So next slide. In terms of challenges, considering the drug development itself, it's been also talked through, but it's true that mainly, and the impact of the expectancy effects or the impact of the functional unblinding is something very challenging, and we need to understand how we can mitigate that. This is not, there is no simple and single answer. It's still early days, and I think early dialogue is very important between developers and regulators, whatever the regulation or the regulatory body is, because it's something that, because of the knowledge gaps that are still out there, it's very important to discuss the development plan as early as possible. The dose is also something that is quite challenging, because also we discussed about the PK/PD potential differences between population, and that's also something that we don't completely know about. So it's also something that has to be taken into account into the drug development program, whether it's important to start with low dose or if we have enough data to define an optimal dose upfront. Another aspect that has been touched as well upon by the previous speakers, but it's also important in terms of regulating the drug, is whether one single dose is enough or if we need repeated dose, and also obviously if the drug has an effect which goes beyond the short-term efficacy, because that's what people will be interested about at the very end, whether or not the drug is able to maintain a long-lasting effect in the patients who have responded in the short term. So next slide. Thank you. So that's more like maybe a bit more details about the drug development programs themselves, but it has also clinical implication. So in terms of patient population, would we allow polymedication? And if not, how is it going to be done in the clinical trial setting, like by discontinuing or slow tapering the drugs. And it will all depend a lot also on the mechanism of action of the drug, whether or not it may interfere with the psychedelic profile. And as we have said before, psychedelic profile are not always fully understood. So it's also adding uncertainty in the way we will be able to optimally design a trial. So the target population, that's a very important topic. So who are those patients? There is kind of, I would not say consensus, but there is a general agreement, let's say, that starting with very severe patient, it's probably something that is reasonable, and then we can extend depending on the results, of course. Safety is to be monitored at any time, and after, obviously, the drug is approved, if so. So next slide. The psychotherapy, this is, I'm not going to go into details, but what is important here is that in the regulatory environment, psychotherapy is not something that is under the remit of the agencies. So it's still something that will come in terms of implementing the drug in the real world with health technology assessment bodies as well. If it requires a certain level of training for the practitioners, for example, if the national healthcare system has the capacity to train the physician. The next slide. Yeah, and I'm done. Yeah, thank you. Thank you.
Thank you, Florence. So we've heard about what scientists have to do to convince regulators, but do regulators also need to make a bit of a mental shift when dealing with psychedelics?
Sorry, I hope I heard your question well, but you're talking about like the paradigm shift when it comes to psychedelics in terms of.
Yeah, what do regulators need to do? Is there sort of cultural suspicion of psychedelics because of their illicit history among regulators? The regulators maybe have to meet the scientists halfway on this.
Yeah, exactly. That's why I think now there is an interest around those drugs, but as I said, there is no prejudice per se. It's really to try to see in a scientific manner whether or not there is a place for those drugs in the therapeutic arsenal for the patients currently, available, and this should be based on scientific evidence, as for any other drugs. So I think it's the debate is not, as I can see, is not so passionate. It's more we need new drugs. There is some preliminary evidence that some of those drugs could work for certain patients, but we need larger trials. We need more robust data, and then we can evaluate. And if there are risks, let's see if the risks are manageable or not. Let's see what the benefit-risk balance looks like.
Thank you. So we've got about 10 minutes. So what I'm going to do is get through as many questions as we can. We've had two questions on the same subject, which is very interesting. We've had two questions about the use of animal models in psychedelic research. So one person says, why do investors continue to provide funding for animal studies in psychedelic research, despite evidence that these models often fail to accurately represent human mental health conditions? And then we've also had a question saying that there's been a rise in papers describing animal modeling of psychedelic therapies, but there's a worry that the use of poorly predictive animal models might be detrimental to the field. Now, this is an issue, I think, which isn't unique to psychedelics. We know that animal models and how well they actually can be used when developing therapies for human mental health conditions is a long-standing issue. But are there any particular challenges in psychedelics which might lead us to rethink our use of animal models? I don't know, Alan, if you have any thoughts on that.
Well, I do, because I mean, a lifetime ago, I did animal research, including animal models, and I think not all animal models are the same. So obviously you can model toxicology effects. You can model addiction propensity reasonably well. You can model neurotransmitter receptor function. So, for example, with the 5-HT2 receptor, you can measure the head twitch and so on. And I published papers on this over 30 years ago. I'm quite skeptical of the validity of many animal models of psychiatric disorders per se. I think they may be most useful for anxiety disorders and least useful for psychosis. But the question is, animal models need to be examined for their fitness for purpose for each of the particular experiments. I certainly wouldn't bet the house on animal model effects, which model psychiatric disorders, given that I've made the caveats about the others. But there may be some helpful information provided which would support doing further studies.
Thanks. Pim and Florence, do you have any thoughts on this, on the use of animal models in psychedelic medicine?
Well, it's not really my field. I know not very much about it, but I don't think you can use animal models to say something about psychotherapies. I think that's too artificial to say anything about that. Maybe you can model something like psychedelics, but from the top of my head, I would agree with Alan that I'm not very optimistic about the validity of animal models for mental disorders, and certainly not for psychotherapies.
So we keep returning to this issue of the psychotherapeutic component of psychedelic therapies in this discussion. And this links into the next question, which I have, which is that someone asks, what types of developments have taken place in the US and the EU in order to provide access to medical use of psychedelics? And this is sort of a broader issue, which is supposing we found a great phase 3 trial tomorrow, which showed how fantastically psychedelics and psychotherapies work. Do we have health systems which are really geared up to deliver these therapies? And if not, what would we need to do? I wonder who'd like to take that question first, Florence, Alan, or Pim?
Well, I mean, unless anyone's going to jump in, I can. I mean, I think the problem with psychedelics and many of these things is that we tend to see things in a very dichotomous, good or bad. This is a miracle, new treatment, or this is a curse. And of course, everything is a bit of a mixture of that, including new therapies, which can actually be good for some people and not so good for others. And Florence and Pim, I think we're talking about personalizing and selecting the patient. I actually think that healthcare systems can adapt very quickly if there's good evidence of a treatment being efficacious. And I think we now have a mechanism not only for looking at efficacy and safety, and Florence talked about that, but we look at health economics, and of course we have NICE and various other regulatory agencies. I would actually just say that I sometimes feel that our psychiatric treatments are not evaluated either in as timely a fashion, or the need for them is perhaps not seen by certain regulatory, not the licensing agencies, but more the NICE type bodies, in quite the same urgency as we see for oncology. And I think that's a shame, because I think these disorders are as impactful. But I think if we've got good evidence of efficacy and safety, and it fits the DALIs and so on, then the case for adopting it would be just overwhelmingly powerful.
Thank you. Florence and Pim, do you have anything to add to that?
Yeah, I think in terms of obstacles, when it comes to implementing the potentially, those new way of treating the patients, there are also a number of uncertainties that for HTA bodies, for the health technology assessment bodies, may be challenging. And it's, for example, when we are not fully sure of who are the patients who may benefit the most, and whether or not, they would need in or outpatient setting. And I mean, for how long they will be treated or frequently. So it's, and in terms of capacity also, we talk a little bit about training the physician, training the psychologist. So it's also to the medical, societies to indicate how those drugs can fit within the current arsenal to treat the patients. It's not for it's not something that regulatory bodies will tell about. It's more for the medical societies as well to help. So I think it's a collaborative really field because it's a change, as you said, in somehow in treatment paradigm, and really it requires a lot of collaboration and early dialogue between the stakeholders. That's maybe a big change compared to traditional medicine.
Thank you. So, sorry, go ahead, Pim.
I think that the mental health field could relatively easily adapt to the use of psychedelics. I mean, my students, when I was still a professor, every student, all students were so enthusiastically about psychedelics. You can train a task force very easily, very quickly. And I mean, I don't know how it's in the UK, but in Holland, you can go on a weekend to have ayahuasca, which is very similar. And I think it's pretty dangerous to do that. But I'm not so worried about whether mental health can adapt to the use of psychedelics. I'm not sure whether we should do that too quickly. I mean, mental health treatments are not that effective, and we should realize that and understand that and try to improve the treatments that we have and deal with the problems we have, that people don't respond, and do that in the most rational way, instead of trying to develop all these new treatments all over again, and then they're not effective, or maybe they are a little more effective. But in the end, that's not changing the mental health field. What changes the mental health field is that we look rationally at what treatments do, what they can do, and how you can improve that. And new treatments, yeah, we should do research on that. And I certainly support research on psychedelics because it has a different mechanism. But we should be a bit more hesitant to walk all the time after all new innovations to see if that solves the problem. It won't. It will still be a small solution for a small group of people, and the big problems are still there. And we should solve the big problems.
Thank you. So we're running dangerously short of time, unfortunately. We are not going to be able to get around to all the questions. What I will say in passing is that someone has said, thank you, Pim, for talking about your own psychedelic experiences and pointing out that it's refreshing to hear researchers being open about this, and wondering if perhaps you have to retire, however, before you can talk freely about these things. But we'll have to leave that issue hanging because I have a final question for all our panelists, which we're going to answer in 280 characters or less. And that is, what is your worst case and best case scenario for research into psychedelics? So I'd like to start with Florence.
Thank you. Thank you. So worst case is that we manage to run trials, we manage to show evidence in a certain population, and we are struggling to implement.
Thank you.
Yeah.
Alan.
Yeah, well, the best case scenario is that psychedelics prove to be helpful treatments for some people with severe mental health disorders. I disagree I mean, I agree with Pim that there are big problems and we should try and address them, but I disagree that we're going to get big solutions. I mean, I think if you look at other areas of medicine, cancer, for example, they've solved some cancers but not others, and I think that's the way forward. In terms of worries about psychedelics, I do worry about the adverse effects, and I do worry about making things worse. And a bit like Pim, I sort of think that psychedelics may suck the oxygen away from other research that we should be doing. Oh, you've muted, Niall, you're muted.
Thank you. Yeah, I'm having a little bit of trouble getting off the mute button, but I will finally turn to him.
Yeah, the worst case scenario is that we invest a lot of money and don't get better treatments. And the best case scenario is that we do have better treatments for a few people. But it will never be a very big thing. So even the best case scenario is pretty modest.
Thank you very much. Thank you to all our panelists. Thank you to all our guests for joining us today. And thank you to IAMHRF for organizing and running this webinar. You will, if you've attended, be getting a little bit of feedback form, a poll. So please do fill that in. And the recording of this webinar will be available online. But for now, thank you again to all our panelists. It's been a great discussion, and I look forward to continuing it in the near future. Goodbye.
Thank you very much. Thank you.
Thank
Bye.
you.